Welcome everyone to our panel discussion, this time dealing with blood flow augmentation. I have several people here to participate in this conversation that I think will add a lot of useful information to your decision-making process about these technologies. Joining us from Tennessee is Katie Hall. Katie, tell us a little bit about your background.
Thank you, Mick. My name is Katie Hall, and I have been a paramedic for about a little over 5 years now, in EMS for a little over 11 years total, in a rural setting, primarily in Monroe County. It's kind of, I think, Sweetwater area between Knoxville and Chattanooga, as far as our larger destinations that we transport to. And I recently made a transition into the in-hospital setting as stroke coordinator here at UT Medical Center.
Excellent. So glad you're able to join us, Katie.
Thank you.
Also, yes, absolutely. Also joining us from Tennessee, coincidentally as well, is Dr. Joe Holley. Dr. Holley, a little bit about your background.
Hey, hello, everybody. My name is Joe Holley. I am the EMS medical director for Memphis Fire Department and several other 911 response agencies in West Tennessee. And I'm also the EMS medical director for the state of Tennessee and a longtime dabbler in the cardiac arrest resuscitation research arena.
Wonderful. So glad you're able to join us today, Dr. Holley. Also here is Justin Hurzeler. Justin, you're here as a supplier side representative as well as a clinician. So if you could give us a little bit about your background and position.
Certainly. Greetings, everyone. I'm Justin Hurzeler. I'm coming to you from Austin, Texas, my gear room / home office, so please excuse the clutter. I am a clinical support specialist for EMS for Zoll Medical. So I travel all over North America doing education and clinical support for EMS agencies. Prior to that, I spent almost a decade in the field as an ALS medic and a tactical and rescue medic, traveling all over the state, as well as a clinical instructor and QA/QI officer for my previous agencies. So glad to be with you all.
Wonderful to have you with us, Justin. So when we're talking about blood flow augmentation, there's a lot of facets to this. At one level, we're just trying to do the best we can with basic technique. Then we're maybe trying to do things to incorporate devices that will enhance our manual technique with chest compressions. Then maybe layer on devices to automate the chest compression technique. And then kind of as the layer on top of that, devices we might add to the mix that will alter the physics of blood flow, hopefully in a favorable way, on top of automated or manual technique. So there's a lot to take under consideration here. The people watching this panel discussion will probably have just watched Dr. Holley's presentation on blood flow augmentation technology. So we're going to try to follow on to that a little bit. And let me start the conversation off with you, Katie. In your experience working with different EMS agencies, either directly or in your role now interfacing with a lot of different EMS providers at the hospital, what's your observation been about their use of real-time feedback technology? Is that something that you're seeing is commonly being used in your neck of the wood, literally speaking, or not?
I will say that I have kind of seen that more so in a classroom setting, as far as truly in my practice in Monroe County. Real-time feedback is not necessarily a part of the equipment that we utilize, aside from maybe through our cardiac monitors by way of capnography readings in moments of providing chest compressions. As far as other kind of mechanical devices and things like that, it's not something that we've really utilized much.
Now, Dr. Holley, I believe that a lot of the agencies you work with have been utilizing that technology. If you could just kind of comment on how widespread it seems in your view, even looking at it from a state or national perspective, that agencies are using these technologies.
Well, we are seeing, I think, more and more as that technology gets better and better and easier to use. And can encompass everything from feedback that is delivered through a sensing device that's placed on the patient's chest, and then you do CPR on top of that, and it gives you, rate, depth, release, all that sort of stuff. Those are excellent technologies. But I think you can also think about this in terms of really simplistic ways to be able to do this, and that may be something as simple as having an EMS supervisory person who's on the scene of a cardiac arrest, who's looking at the watch and ensuring that folks are ventilating at the right time and that the compression rate is where it needs to be, and just giving visual feedback is extremely important to ensure that folks are maximizing their efforts in CPR.
Indeed. And but in the cases where they're actually using technology to provide the real-time feedback with the accelerometers, the pucks, if you will, in your observation, were they generally measuring their compression technique performance before they implemented this and had an opportunity to do it afterwards and get any sense of a delta?
That's a great question, and the short answer is no. I'm not sure that they have been aware. I think part of the challenge that we face is most everybody in the EMS response world thinks that we do pretty good quality CPR. And in reality, we don't do very good quality CPR without tools to help us stay within a fairly narrow set of parameters where we are maximizing blood flow.
So, Justin, you've got clinical experience considerably as well. What's been your observation in your part of the country about use of these real-time feedback technologies? Is it rare? Is it ubiquitous? And what sort of measurable impact has it seemed to have had in your observation?
Thanks, Mick. I would say by no means is it ubiquitous at this point, not only in my own area down here in Texas, but also the agencies that I encounter throughout North America and the work that I do. There are many agencies who are utilizing CPR feedback and recording the data and using that data to, improve and target training. But there are many agencies who are also not using CPR feedback. And some of you may have seen me on this soapbox before. I think that, we need to agree on having high expectations in EMS throughout our country. And part of that is being able to measure what we do and improve upon that. And without CPR feedback, I don't think that's possible. And now, with the advent of real-time ventilation feedback, we have even more opportunity to do a far greater job than we have been doing in the field. Obviously, ventilation may appear to be only, affecting oxygen levels and things like that. But when you take into account intrathoracic pressures and preload, then it also strongly affects the blood flow and perfusion. So, we need to measure as much as we can and record the data and train accordingly.
So, we've talked about, the accelerometers or whatever technology any particular manufacturer chooses to use to measure chest compression performance. But even with just standard defibrillation pads, I think the manufacturers are able to provide a data file that not only shows us the ECG rhythm, but we can also discern, what the compression rate is and where you see the gaps in the rate. We can see the perishock pauses and those sorts of things. To what extent, Katie, have you observed that agencies, even if they don't have the accelerometers, as you mentioned in your area, they don't, are they harvesting data files and trying to make the most of the data that is available in the defibrillators at this point?
I'm not sure that they're actually able to harvest that information. A lot of the areas that I'm most familiar with are primarily volunteer-based departments, and sometimes their resources and kind of their knowledge of that information that those defibrillators can provide may not necessarily be readily available to them. But in my area, we do typically kind of fall back to just kind of, as Dr. Holley was talking earlier, kind of someone taking lead to make sure that things are happening appropriately and, you know, kind of carried out in the best way on those scenes.
Okay. Let me kind of keep that rolling a little bit. Dr. Holley, in the places where you're familiar with that they're not using the accelerometers or similar technologies, are they harvesting the data files out of the defibrillators and extracting at least compression rate, pauses, and you can sometimes infer ventilation, you know, from the rise and fall of the ECG baseline if they don't have a capnography channel in there. But are they utilizing it even without the accelerometers?
I would say that that's extremely inconsistent and much more uncommon than it ought to be. You are correct. There's a lot of pretty solid data that can be gathered from even the most basic of equipment. And many of them now have the technology to sort of see through the ECG tracing to pick up compressions and that sort of stuff. So there's a lot that can be learned there, and I do not think that we take advantage of that nearly as much as we should or as consistently as we should.
Justin, how about in Texas and the Austin metro area? Is that stuff being harvested?
To the best of my knowledge, and certainly prior to my departure from the field, yes, absolutely. The two main EMS agencies that I have experience with in this region use CPR feedback real time and also harvest that data and do, you know, debriefs with the crews as soon as possible after codes are run, using this sort of performance summaries from that data. I do think I agree with both of you that, you know, there is data to be harvested from pads alone, but I think, you know, the pads measure impedance primarily in that case, and I think that, you know, that in itself, while it's a good start, is still lacking in terms of things like depth and recoil and all of those things, which play a pretty major factor in how effective our CPR is. So I'm glad to say that, yes, it's absolutely being utilized in this region. But again, I also deal with agencies, you know, across North America, and it's, as Joe pointed out, pretty inconsistent.
Yeah, unfortunately, that's been my observation as well. So we've talked so far about basic technique, trying to get some basic data. Now I want to take this next layer on top of that with blood flow augmentation and automation of the process as a means of improving blood flow. Katie, I'm going to come back to you again to start us off. To what extent are you seeing the use of automated CPR technologies to improve blood flow during resuscitation?
I will say that for a few years now, we've utilized different devices in it. They implemented that each truck has a device for automatic compressions. With the rural setting and majority of our fire department personnel are volunteers, you may or may not get a lot of help during the day of normal business hours throughout the week, because the beauty of being a volunteer is the fact that you can kind of pick and choose when you're available, and many of them have other jobs. So you pulling that equipment into the play is kind of a game changer. It's looked at as a third man on the truck, truly, because that does free up both providers in that moment. And then in transport, you know, you kind of have another set of hands, and, you know, to err is human, and we most certainly are, especially in that time frame where we're traveling down the roads, you know, considering lights and sirens, and the East Tennessee roadways here are by no means clouds. So, you know, it can be a pretty rough ride, and having that equipment there to make a good compression every time makes the difference for those patients.
Yeah, so it sounds like you're using it perhaps fairly early in the course of a cardiac arrest. So is is it being used on most of the arrests, or regardless of transport? And if it's being used on scene, at what point are you usually introducing the machine?
Typically, we will start with manual compressions. And as far as the equipment that you bring in to the residence, in a situation like that, that usually comes off the truck with the crew. But we will almost always start compressions, manual compressions. And if the patient's size allows for us to utilize that equipment, we try to implement that within the first few cycles.
Okay. Okay. Now, dealing with more of a metropolitan area, Justin, in your experience, again, around Texas, Austin, et cetera, are they using the automated CPR technology as more of a force multiplier or something to ensure more consistency, perhaps only during the transport phase? How is it worked into the resuscitation workflow?
It's a great question, Mick. My experience has been that I think we're really dealing with two issues there. The first being, of course, what resources are available to the agency and how many devices can they afford to keep. My previous agency, we only had automated CPR on the commander's vehicles. And then several of the agencies that we worked in close conjunction with, the fire departments, also had automated CPR devices on their commander's vehicles. So it was pretty common to have it available on the call, but it was not a certainty by any means. However, I think it's pretty agreed upon, at least in this area and to a great extent in the agencies that I deal with, that we can't do compressions in the back of a truck while we're moving. Manual compressions just don't work when you're transporting a patient. So certainly the policies that I was familiar with, we would not transport unless we had automated CPR. Yeah, I would point out that I recently attended a presentation for the ACR model that's being put forth by certain agencies around the country. And I noted with interest that they advocate applying automated CPR at the very first opportunity that you can. And their reasoning behind that is that, without a good perfusion index, there's very little chance of resuscitation at all. So you may as well just get automated CPR going and have it there and doing better compressions than humans will throughout the entire code.
Okay. And the ACR model, elaborate on what that is.
I believe it's advanced cardiac resuscitation, if I'm correct. And it originated in, forgive me, I'm blanking on the original agency who did it. But it essentially consists of 7 different steps. The first of which is automated CPR applied right away, having an ITD in place to decrease intrathoracic pressure. No defibrillations until CPR has been going on for a sufficient length of time to generate a blood pressure in the patient. Excuse me. And there are several other steps too. I'd have to refer back to my notes to see. This is my first encounter with it. So.
All right. And Dr. Holley, if you could comment on how automated chest compression is blended into the workflow. Is a force multiplier as a quality assurance of good technique? Just how does it fit in your experience?
I think it's yes to all of those things. And Justin, I think you might be referring to Rialto, California, for that bundle of care. I think that much of what you've heard here, I agree with completely. Mechanical CPR devices are certainly, try to say this the right way. People can do just as good a quality CPR as a machine can, as long as people do it perfect, but people don't do it perfect for very long. And so mechanical CPR devices have a huge advantage over people in that they can consistently deliver very high quality CPR. that people struggle to do. So I think there are great advantages to mechanical CPR devices in their consistency. They certainly function as a force multiplier, particularly if transportation distances for cardiac arrest patients are long and you routinely attempt to do CPR in the back of an ambulance. And as Justin completely accurately said, it is a complete waste of time, quite honestly, for the patient, and puts your provider at very high risk in the back of that truck, trying to do that, balance himself, and perform CPR at the same time. So I am confident in saying that the risk-benefit ratio of that activity is less than zero. It is not good for anybody. So I think that's a place where they have great advantage. And again, sort of back to the consistency issue, in that you can then relax your or change your focus to other things that you need to make certain are being done correctly, knowing that the device is not going to change rate, depth, et cetera, until you physically make a change to it. So it allows the providers on scene to refocus their attention to ventilation, medications, shock, whatever other parameters that need to be taken care of.
Sure. So now, we've talked about basic technique. We've talked about things to kind of help us monitor basic technique and optimize that, and then automating it. Now let's add this final layer on of other devices that will try to manipulate the physics of blood flow in a favorable way. So I'm going to come back to you again, Katie. To what extent have you seen people using other devices, be it intrathoracic impedance threshold devices, suction, active decompression, plungers, if you will, on the chest, heads-up CPR? Has any of that started making any traction in your area of the state?
Kind of historically speaking, the plunger action for the mechanical CPR devices, where it can kind of gauge the appropriate depth of those compressions, and it kind of gradually moves into the right depth, is primarily what I'm the most familiar with in the area.
Yeah, and actually what I was talking about more is the device that has a suction cup on the end, and you're actually pulling the chest wall back out. So you're using that to do the chest compressions, and then the ITD attaches to the end of your advanced airway. Are you seeing use of either of those devices in your area?
No, I'm not very familiar with either of those devices that are kind of known in this area.
Okay. And Dr. Holley, what's been your experience with those technologies?
Well, quite a bit on all of those different technologies. We routinely utilize the ITD on all of our cardiac arrests. And in a couple of services that I work with, we are doing the active compression, decompression CPR that you described, where you actively lift up on the chest.
And how about any of the variants of the heads-up technique? Has that been getting any traction yet?
So that is early in its clinical trials, is probably not the right word, because we're really working more on the operational and logistics side of that. I do have one service that is participating in an early field rollout of that, with so far pretty impressive results. Obviously, the challenge there is another piece of equipment to purchase, maintain, and utilize. And then really in the big picture, how do you fit all these different pieces of technology together in a way that is efficient and maximizes the benefit of all of them?
Very good. And how about in the Austin area, Justin, and Texas in general, perhaps?
Well, I can't speak to current practice right now because I haven't been in it for a little bit, but certainly ITDs have been around for quite a while and are utilized to the best of my knowledge, by most of the major EMS agencies in Texas. Heads up, as Dr. Holley pointed out, is still relatively new, and I think is still being looked at pretty closely by most medical directors before they start implementing it on a widespread basis. I don't recall seeing very many agencies using active compression decompression devices, nor have I come into contact with very many in my work for Zoll. But you know, they are out there, and the studies have been pretty good on them as far as I've seen. I think that many of these things, much like real-time feedback and other devices that we have available, are very slowly gaining traction in EMS in North America, and it's going to be a long time before we see them in very, very widespread use throughout the country, I feel.
And then to kind of wrap this up, Justin, if you could reflect a little bit on what you commonly see agencies struggle with as they try to implement automated CPR or ITDs for that matter. What sort of issues do they commonly run into that gets in the way of their success, or at least slows it down?
Absolutely. You know, part of my work as a support specialist is going to agencies and helping them with their data post-code. So I go in and review the data with them and show them ways to evaluate that, best target their own training. And certainly the most common issue that I see, especially with agencies that are adopting new technologies, are pause lengths during codes. When they're implementing mechanical CPR, there tends to be a very long pause unless they've trained extensively on a stepped process for applying that device. And that is absolutely the biggest problem that I see over and over and over for agencies.
Yeah, and the prescription for that particular problem, Dr. Holley, I think you'll back me up on this, is train, 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 and then train some more.
Absolutely, and I think to Justin's comment, you know, one thing I have seen with many services around the country and the world actually that have pushed to implement these new technologies is 6 months or a year into it, their cardiac arrest survival rates haven't changed much, and they are quite frustrated with that. And they're quick to say, well, that fill in the blank just doesn't work. And in reality, the answer is usually many of the things that Justin just talked about. For mechanical CPR devices, it's too long a pause to get the device in place and get it operational. There's pretty good data out there that says any pause longer than about 25 seconds during a cardiac arrest doubles your patient's mortality. So your chances just went down by 50% immediately, no matter what the reason for the pause. And if you look at devices like the impedance threshold device, which does exactly as the device is designed to do, but if you're not doing good quality CPR underneath that, then the device will show virtually no benefit. And that's been borne out by a very large number of studies. So it's all about the basics. It's all about training, and then ensuring that before you implement these devices, that you are aware of the factors, in the basic factors that are going to have a influence over the performance you're likely to see out of these devices, so that you can ensure that you are maximizing the device's impact in your setting.
Absolutely. So I'm hoping that everyone is kind of getting the gestalt out of the consensus of comments here, that we've got to make sure that we're doing very, very good basic CPR. It's great if you can close a performance feedback loop and measure that performance by trying to harvest whatever data you can out of your defibrillator monitor and providing feedback, even if you're not using real-time feedback and accelerometers as part of your equipment package. Leverage the data to the best of your ability. And you've got to really have perfected your manual CPR technique in order to appropriately incorporate your automated CPR technique. And you got to have all that nailed down before you then add the last layer, the icing on the cake, if you will, with some of these physics augmentation devices, I'll call them, whether they're ITDs or active compression, decompression, heads-up CPR, etc., to kind of supplement the physics elements of blood flow. So I appreciate everyone being on the call today. Hopefully everyone's gotten some good information that you want to keep in the back of your head as you're contemplating your purchasing decisions for these sorts of technologies. And right after this panel, we'll go into the next session with a live Q&A. So be thinking of your questions and comments for that section of the conference in just a moment. So thank all of you for being here. Thank you so very, very much.